Congenital coronary artery anomalies are a diverse group of malformations involving the origin, course, or structure of the coronary arteries. While most are benign and discovered incidentally during angiography or CT, certain subtypes carry a higher risk of myocardial ischemia, heart failure, or sudden cardiac death. Congenital coronary artery anomalies are generally categorized based on their functional significance. Hemodynamically significant high risk. These anomalies can compromise myocardial perfusion, especially during exertion. Anomalous origin from pulmonary artery, Al-Kappa, most commonly the left main, known as Bland-White-Garland syndrome. It leads to a steal phenomenon where blood flows from the coronary system into the low pressure pulmonary artery. Interarterial course, malignant course. An artery, often the right coronary artery, originates from the opposite sinus and passes between the aorta and the pulmonary artery. Compression during exercise can lead to sudden death. Congenital atresia, complete absence of a coronary ostium, usually the left main. Coronary artery fistulae, abnormal communication between coronary artery and a cardiac chamber or major vessel. Example, right ventricle or pulmonary artery. Hemodynamically insignificant, benign. High takeoff, origin of the ostium more than 1 cm above the sinotubular junction. Duplicate vessels, such as a double left anterior descending artery. Circumflex from right sinus. This is the most common origin anomaly and is typically asymptomatic unless it takes a retroaortic course that complicates valve surgery. Given the complex 3D anatomy, traditional invasive angiography is often supplemented by advanced imaging like coronary CT angiography, the gold standard. It provides superior spatial resolution to define the malignant interarterial course. Cardiac MRI, excellent for pediatric patients to avoid radiation and for assessing myocardial viability or ischemia. Transthoracic echocardiography, primary screening tool in infants, especially for Al-Kappa, though limited in adults by acoustic windows. In young athletes, anomalous coronary origins are the second most common cause of sudden cardiac death after hypertrophic cardiomyopathy. The malignant course is particularly dangerous because exercise-induced expansion of the aorta and pulmonary artery can pinch the anomalous vessel, leading to fatal arrhythmias. While congenital coronary artery anomalies can occur in isolation, they are frequently associated with various other structural congenital heart diseases. In the context of complex CST, identifying coronary anomalies is essential as an abnormal coronary anatomy often dictates surgical approaches and complicates myocardial protection during repair. Certain types of congenital heart disease have a high prevalence of associated coronary anomalies. The specific anomaly often varies with the type of heart defect. Coding of coronary arteries according to the Leiden convention: 1. Sinus 1, 2. Sinus 2, L. Left anterior descending, CX. Left circumflex, R. Right coronary artery. Example, 1L, 2 CXR. That means sinus 1 gives rise to LAD, sinus 2 gives rise to circumflex and right coronary artery. Detransposition of great arteries is almost inherently associated with variations in coronary anatomy because the coronary arteries must arise from the posterior great vessel, which is the aorta in this condition. The single most common anomaly in DTJ is the left circumflex artery arising from the right coronary artery. That will be 1L, 2 CX are in the Leiden classification. A single coronary artery arising from the left sinus is also common. The primary surgical treatment, the arterial switch operation, requires the transfer of the coronary buttons to the neo-aorta. Complex coronary patterns make the operation significantly more challenging and increase the risk of procedural myocardial ischemia. Coronary artery anomalies occur in roughly 5 to 10% of cases of classic tetralogy of Fallot. The most common is the left anterior descending artery arising from the right coronary artery or right sinus of Valsalva and crossing the right ventricular outflow tract. Other variants include a dominant right coronary artery or single coronary artery. A coronary artery crossing the RVOT is a major surgical contraindication for a large transannular patch, as it runs the risk of transection during ventriculotomy. This scenario often requires an alternative repair strategy, such as placement of a right ventricle to pulmonary artery conduit to bypass the vessel. Congenital coronary artery anomalies, particularly coronary sinusoid fistulae, are extremely prevalent in pulmonary atresia with intact ventricular septum, affecting up to 30 to 50% of patients. Coronary sinusoid fistula occur from the high pressure region of the right ventricle and forces blood through persistent sinusoids into the coronary circulation, that is the RV dependent coronary circulation. Another anomaly likely is coronary artery stenosis or atresia. Decompressing the high pressure right ventricle in pulmonary atresia with intact interventricular septum can paradoxically cause fatal myocardial ischemia if the ventricular coronary fistulae and associated proximal stenosis mean the circulation relies on the high RV pressure for perfusion, that is the coronary circulation. Surgical strategies must protect this delicate RV dependent coronary artery circulation. Truncus arteriosus associated with single coronary artery patterns and anomalies in ostial location can complicate placement of a surgical conduit. Single ventricle physiology like hypoplastic left heart syndrome. In this condition, though coronary artery anomalies are not universally present, abnormal coronary connections can complicate the complex staged reconstruction like Norwood Glen Fontan procedures by creating combating runoff or limiting venous return. Supravalvular aortic stenosis, as in Williams syndrome, is associated with unique coronary issues where the arteries are exposed to high systolic pressure, leading to tortuosity, dilatation and premature atherosclerosis and coronary ostial stenosis. Because of the distal location of the supravalvular aortic stenosis, proximal region from where the coronary arteries arise are in the high pressure zone. Here is a summary. In DTGA, circumflex can be from right side. There could be single coronary artery from left side, and these complicate coronary artery transfer during arterial switch operation. In tetralogy of Fallot, a lady can cross from RCA across the RVOT, which precludes a large transannular patch and requires alternative conduit repair. In pulmonary atresia with intact interventricular septum, right ventricle to coronary fistulae, stenosis of the arteries or atresia, decompressing the RV may cause fatal ischemia in these RV dependent coronary circulations. In truncus arteriosus, high or abnormal ostia, single coronary artery patterns also influence surgical conduit choice and placement. In complex congenital heart diseases cases, advanced non-invasive imaging, particularly coronary artery CT angiography, is often vital to accurately define the coronary anatomy before repair. Cardiac MRI is also used, though CT provides better resolution. While intra-arterial course is the primary malignant abnormality in isolated hearts, in complex congenital heart diseases, the definition of risk shifts to how an anomaly restricts surgical feasibility or poses unique risks to survival. Example, the crossing artery in TOF or RV dependence in pulmonary atresia with intact intraventricular septum.